Good morning, good morning, good morning, and welcome again to the Great Lakes Health Radio program with your host, Francesca Messiah, Kaleida Health, Manager, Workforce Development. And you're listening to us on Power 96.5 FM, or you might be listening to us on WUFO 1080 AM, or you might even be listening to us on one of your favorite streaming services through the uh, internet. And I just want to say welcome back, because hopefully you've heard the show before, but if not, I want to say thank you. I want to say thank you for listening, and I want to say welcome to our new listeners. Welcome to our existing listeners. Every day's a new day in my book. Um, Kaleida Health. Who is Kaleida Health? Where were hospitals? What hospitals? We're Buffalo General Medical Center. We're Gates Vascular Institute. We're Oishei Children's Hospital. We're Millard Fillmore Suburban. We have two long-term care facilities, one called High Point, which is in Buffalo at Michigan and High. The other one, DeGraff, located in North Tonawanda. We have 24-hour health care services for all ages, all types of medical conditions, and that's called the Visiting Nursing Association, affectionately known as the VNA. We have clinics throughout Western New York. We have clinics, we have diabetes, we have ortho, we have women's health clinics, and hopefully we've touched on many of them throughout the years we've been on the radio. And speaking of that, if there's something you want to hear and I see you out in the community, please share those with me, because I can't think of everything. I try to, but I know I can't. So I value your opinion on the programs, and I value your suggestions for new topics. Well, let me just say a little more about Kaleida Health. Kaleida Health does not discriminate, exclude, or treat people differently because of race, color, religion, sex, national origin, disability, sexual orientation, gender identity, or expression, physical appearance, source of payment, or age. So I just want to make sure that, as we work in this climate, that you know that you have a friend here at Kaleida Health. Well, moving on. October is Breast Cancer Month, or Breast Cancer Awareness. And that's our topic for the first half of the program. Um, and our guest for today is not a stranger to the show. Matter of fact, she is one of our many friends, but she's a friend of the show, and that's Melissa Wanzer. Did I pronounce your last name correctly, Melissa?
Yes, you did.
Okay, thank you. And Melissa has her EDD, which is like a PhD, and it's like it is a PhD, and she is a manager of survivorship and supportive services, specifically in the area of breast cancer. And Melissa is our guest because she's knowledgeable, she's good, and she's going to share, and she may share a little of her story on how she got involved with breast cancer. But my first question to you, Melissa, I want to say welcome to the program.
Thank you. Thanks for having me back.
Oh, you're welcome. Now, it's October that's Breast Cancer Awareness Month, correct?
Correct.
Yep. And I just want to say to our listeners, October is Breast Cancer Awareness Month. However, you can get breast cancer at any month. It's just an awareness, and maybe that's the month where more people are screened. But I just want to say, Melissa, why is October Breast Cancer Month?
Yeah, so October was selected as Breast Cancer Month because this is when early advocacy efforts took place around the 80s. And actually, the month of October was chosen by the American Cancer Society in collaboration with Imperial Chemical Industries, and this is around 1985. And so it seems arbitrary. I mean, I think that's a good question, and I had to research this myself, to be honest, but I think it really does coincide with these, early efforts to get women to bring to the forefront the importance of mammograms, self exams and things like that.
And I want to say for you listeners who watch football, you'll also notice around this month you'll see men wearing pink ties. You'll see football players wearing pink cleats. And you didn't always see that. And again, it's all because of the awareness. You might see me and I may have something on pink, but I try to wear pink almost every single day because my sister had breast cancer. And I would love for people to say, don't you, how come you always wear pink? I've always worn pink, but it's just that it's just a pink is it's like an awareness color, right?
Yeah, I mean, I'm assuming they chose pink because, it's largely a female disease. But I will comment on that. I think that a lot of people will ask, like, why is there, so much emphasis, on breast cancer, and when there are so many different types of cancers. And thankfully, other cancers have designated months, and there are awareness initiatives. But one of the reasons there's, I think, so much is because there's such a high number of women. I mean, 1 in 8 women will be diagnosed with breast cancer. And that's a really high number, and it's concerning. So all this work that you've seen over the last,
Since
40 years
1985.
has been since 1985, which, right, is a long time. I mean, like, I was in high school, right? Since that time period has really been instrumental in increasing the efficiency of diagnostic testing, more information on when women should be screened, and improving the efficacy of the treatment and the efficacy of you first identifying cancer, but also the treatments, right? That women have a better outcomes. Women with breast cancer have better outcomes because of all those early initiatives and those advocacy efforts.
And pressure, but we pressure from community, but that's another topic. I chuckle because I've written questions out, but I could go on and on talking about this. Let me just stick with the questions. Um, how did you get involved in working in the area of breast cancer?
Yeah, so there are a number of reasons. First, I was diagnosed with breast cancer in 2016. And so I went through that process of, being treated and chemotherapy and surgeries and radiation and, all of it. And it was transformative because prior to that time, I had been, pretty healthy and hadn't haven't any major, kind of major health issues. And I realized that it's a marathon, not a sprint. And I also realized that, I had time, I made me reevaluate my time left on this planet and how I wanted to use that time. And so I started working with the American Cancer Society. I was on their board. I did a lot of work with Making Strides, and raised money with friends with that. That was really a great experience meeting people through that initiative, realizing how important that fundraising is, and that money goes to research, again, to save and to support women like me who are affected by breast cancer. Um,
Hmm.
and then I retired from my teaching job at Canisius University. I was a professor there for almost 27 years. And I decided that I wanted to work in survivorship. And ultimately, the initiative or the mission with survivorship is to help people affected by cancer stay healthy, to help them stay healthy and well throughout their life. And so that's something that resonated with me as well.
Yeah, no, thank you. So like I said, Melissa has been through breast cancer. Listeners, I might make sure our listeners know. And we'll talk a little more about that later in the question. So she's qualified to talk about it because she has experienced it. Um, why should women get screened, and how about men getting screened?
So that's what I was mentioning. All this advocacy that started in the 80s, has really, the push has been to get screened, right? To get mammograms. And the reason for that is to catch it early, right? So whatever, whatever the cancer is, right? If it can get caught early, if you can get screened and they can find it in an early stage, the outcomes are better, right? It's more treatable, it's more manageable. So, going for that regular yearly mammogram for most women with average risk. So, with average risk, you're going to start at 40. Now,
Mhm.
what does that mean? I think that's a really important thing to clarify. What does that mean to have average risk? Typically, that means that you don't have an extensive family history of breast cancer or cancer in general, not just breast cancer, but cancer in general. So if you don't have a family history of breast cancer or cancer, then you are at average risk and you should start around 40. However, if you have sisters, your mother, your father, you have relatives who have had breast cancer or different types of cancer, and that's fairly widespread, then the recommendation is typically to start earlier. And that's something to share with your primary care, with your gynecologist, and to let them know, and that's why we fill out a health history. And that's why it's so important to fill out that health history and to know your family's health history and to have those conversations about, who's had cancer and when were they diagnosed and things like that, because those are the questions often that are on the health history. When was that person diagnosed? The example I'll give is that both of my sisters, once their physicians found out that I had breast cancer fairly young, both of them now have been getting screening earlier than 40. So they, utilizing that information as well as our family history of cancer, they are getting screened much earlier than 40.
Hmm. And when you say what much earlier, what age?
Well, again, I think that they were just, they were younger than 40. So they were in their 30s, mid 30s. And, I think that that's an important conversation to have with your healthcare provider, right? And, share the information about your family history. If you have someone, who is in your immediate family who is diagnosed younger, they should know that. And then they will make recommendations on, should you start at 30? Should you start? I've met patients who have been having mammograms since they were in their 20s, right? And I don't know if that is, combination of their family history or just other flags, warning signs that emerged and that resulted in them being screened in their 20s.
Hmm. Yeah, you know what? And it's funny that you mentioned that, 'cause I think I've been having mine for a long time. Should they, so let's say your family member has, like yourself, has had breast cancer, and should then that family member get screened more than once a year, or is once a year sufficient?
That is up to the provider. I mean, and again, I'm not a medical expert on this. I think most people go once a year, and unless they find something suspicious, and then I think the screening frequency increases. I go once a year. I do not have uh, I don't have mammograms. Again, and those diagnostic tools have changed, right? So I have an MRI with contrast because that's the appropriate screening tool for me. I think that both of my sisters also, because they have dense breasts, they also have MRIs. That screening tool is going to be whatever the screening mechanism is, will be decided by your provider, and they'll take into consideration a number of different factors. And a big factor there too is the density of your breasts, and that requires screening beyond just a mammogram.
Yeah, so our listeners, again, if you have dense breasts and you have and someone in your family has breast cancer or other cancers, but let's say we're sticking with breast cancer, and they just give you the traditional mammography, I encourage you to ask for MRI. And if the answer is no, ask why. Because sometimes the traditional machine, which has gotten a whole lot better, if you haven't had a mammogram in a long time, trust me, the the technology is much better. It's comfortable. It's no longer that cold thing. So just make sure you advocate for yourself. This show is about education. So thank you. How about men? How about men? If all the women, let's say two or three aunts have had breast cancer, are they at risk of getting breast cancer?
So there is no standard screening guidelines for men. Um, you know, where there are very standard guidelines for women in ages, like I said, that age 40 is important. And then earlier, if there's a higher risk and higher frequency of cancer in your family, and especially breast cancer. The issue that for males is if they present with the BRCA gene. So if they have the BRCA gene, because males can have that gene, then they are going to be screened. They're going to have breast cancer screening earlier, and it around maybe 35 to 40 years old. So, men and women who have that gene are at higher risk for breast cancer and other types of cancer. So the screening guidelines, I think, are much more, I don't know how to, much more rigid, much more structured, because that gene puts you at risk for other types of cancer beyond breast cancer.
For those listeners who've never heard of a BRCA gene, sounds like a broccoli gene, a BRCA gene. How do they get tested? Who would they talk to their, is that a conversation that begins, pardon me, with the primary care physician on getting a test, or is that a part of a routine blood test, this BRCA gene test?
Now, again, that's going to be something, I'm not an expert on BRCA gene, but that will be something that, related to what we're talking about, understanding your family health history. Does one of your parents, an aunt, an uncle, does someone in your family have the gene, right? And usually what happens, one thing that happens, I'll give a scenario, is that, um, you know, my cousins, my second cousin, she has, got diagnosed with breast cancer. Because she came out positive, that information, right, is shared, should be shared with the rest of her family and other members of her family, her children, her husband, children primarily, and then her parents and things like that, to try to determine, um, you know, where that BRCA gene, right, where else that BRCA gene, who else has it. Because again, once you're identified as having the BRCA gene, which the family members, the uncles, their family members were tested, then those individuals are, encouraged to do more screening more often for different types of cancer. So it's kind of like that person that gets it triggers the person who tests positive for the gene, and this is my understanding, kind of triggers communication with the rest of the family to say, all right, you need to get tested, because now this having this gene has put you at risk for not just breast cancer but other types of cancer as well.
And how about prostate? Is there a relationship between, I had heard a while ago, and I don't know if you know the answer to this question, between if your family member has prostate cancer, that you are at greater risk of possibly having getting breast cancer, a reason for screening. Are you familiar with that? Only because
I
it's
do not,
something.
yeah, I do not know the answer to that. I really
Okay.
don't. So I wouldn't want to say the wrong thing.
Okay. So the point is, get screened. Please get screened. Take a friend.
Yeah.
Yeah, go for a cup of coffee after. Um, so a question that I've always thought, and I thought our listeners may also be interested. So when you get screened, and let's say something, what is it that pops up that determines you might have cancer? And are you aware of how does one then decide what phase? Is it level, or what level is it? Level one, level two? So what is it after you have your exam and they see something? what is it that they see that makes of, I guess then the radiologist call you in, and what happens from there? Like, how do they know it's cancerous?
So again, not being a clinician or,
Yeah.
pathologist or anyone who, I can only speak to these things in a very general way. And I would just say that, for let's just use women, right, and
Sure.
mammograms. And I'll just use my experience that, there are a number of different ways. So I went in for my normal mammogram, my yearly mammogram, and they saw something suspicious on those images, right? The pathologist said, okay, there's something, or I'm sorry, the radiologist said there's something concerning on here. Come back for additional screening. And so I had an ultrasound, and then the ultrasound, again, showed something concerning, something unusual. And so then I was sent for a number of different diagnostic tests, CAT scan, MRI, PET scan. And so, there is a trigger, right, with that original mammogram. Something is abnormal, something is there that wasn't there a year ago. And so that imaging, right, the radiologist looks at that, and then that triggers additional, we should look into this further. And really, that is that is very stressful. I mean, not surprisingly, that's one of the more stressful times because, Francesca, it is the unknown. They are clearly concerned. And so you are going for, it is not unusual. And I try to explain to patients going through this that it's very scary, but they're trying to identify exactly what's going on and what's the best tool. The type of cancer that I had was not ductal. So most breast cancers are ductal. You hear women talking about, I found a lump. I found a lump. And that often, Francesca, will trigger, they'll call their doctor, I found a lump. They'll say, okay, come in for imaging. But mine was lobular. There wasn't a lump. And so it's not always detected. It's definitely not always detected on mammograms. It's a more unusual type of cancer. And so I had normal mammograms for several years until finally something showed up both visibly and, through the imaging. And they said, okay, this is suspicious. Let's keep doing more and more imaging. So, the answer to that, I think that they see something that is new, that is different, that is concerning, and then they are utilizing a number of different diagnostic tools. So then after they find that, you said, okay, well, how do they figure out if it's cancer? Needle biopsies and biopsies to go in and look at it closer. I'm going to say from the cellular level. And then that's where the pathology comes in, right? All those tissue samples are sent to the pathologist. The pathologist looks at that. So, that's my basic knowledge from my own experience and from what I understand. A lot of imaging. I would mention that a lot of imaging leading up to then a needle biopsy, additional needle biopsies that say, okay, this is what you have. And that pathology is really important because people might not know this, but there are, probably hundreds of types of breast cancer. And so they have to know what exactly you have because that dictates your treatment regimen, what chemotherapy you're getting, when you're getting it, whether what type of surgery you're going to have, and so on.
Hmm. And I just want to say that that's why screening is so important. Number one, as Melissa has going through step by step. So when they think they see something, you don't immediately get chemo or radiation or surgery. It's a process, because the medical professionals want to make sure that they are seeing what they think they might be seeing. And so I don't want you, I want you to go and get your mammography. And if you want, please bring a friend. You can have a friend. Friends can't go into, I don't know, they probably can't go into the x-ray room with you. but they can sit in the examination room with you. Let your friend take notes because as Melissa just said, it can be scary. So let a friend go with you. Let them know, give them enough time to go with you so they can then get the proper notes, because you may hear every fifth word that person is telling you. They may hear, and you want someone to hear every word and not every fifth word. And so it's so important. And I know we don't have much time left, and we'll always come back again. African American women and getting screened. Is it true that African American women, I'm African American woman, is it true African American women don't go as often for screenings?
So the issue is that African American women are more likely to get triple negative. They're more likely to be diagnosed with a cancer that's called triple negative cancer, right? So ER negative, HER2 negative. That's what that means, right? It's triple negative cancer is a more aggressive form of cancer. So African American women are more likely to be diagnosed with triple negative, which is more aggressive, and they are more likely to be diagnosed at later stage, which makes it later stage of cancer, right? So cancer is, as you had said early, Francesca, it's stage. They tell you what stage you are: 0, 1, 2, 3, and 4 is metastatic. So they get diagnosed at a later stage. And one of the explanations, a possible explanation for that, is just what you said, that they may not be going for regular screenings. So, that is, I saw that as one of the questions that you shared with me, why aren't people going for screenings? And that can be so many different reasons, right? You prioritize your family and your family's health. You don't have great insurance. Don't have a way to get there, right? Maybe to the screening, because, and fear. And I talk with women who just say, I would rather not know. And I think that's a safe space. Like, I will take care of this when I need to take care of it. And I just am taking care of all my other business and all the other things that I have on my plate. And I don't have time to prioritize my own health. So that's the tough thing, is encouraging women and saying, please don't put, when we were going out to health fairs and talking about health events and wellness events, you have to prioritize your health because your family needs you to prioritize your health. They need you to go and get those screenings and not skip them.
Mm-hmm. And you know what, Melissa, we are really out of time, but I have an event coming up this weekend with a group called the Links. Do you have something? I don't have anything on breast cancer to share with the women. Can I contact you later
Yeah.
and get something to
Yeah.
send? Okay, and we have like about 30 seconds left. So what is your last thing you would like for women to hear?
I mean, we can't say it enough. I think if you see something that is unusual, you feel something that is unusual, share that with your provider. Don't let fear be debilitating. Don't let it become paralyzing for you, because you really should share that information and go get screened, go have someone look at it, whether it's an exam or, a physical exam or a screening, mammography or other tests. So just please don't wait. Don't wait.
Don't wait. And I want to say, a doctor can't read your mind. If you know you have not been screened in a year or so, don't, and you're like, oh, my doctor didn't ask me, my provider didn't ask me. Eh, but wrong answer. It's your health. Go take it. If you have to ask their office where to go for screening, but you know best if you've been screened. So, on that note, Melissa, I want to thank you for talking about breast cancer awareness. Know your family history. And ladies, please get screened. Right, Melissa?
Absolutely.
Yeah. So thank you again for being our guest on the Great Lakes Health radio program. And listeners, hold on. Wait, we have another program coming up in about 15 seconds. See you on the flip side. And now on to part two. Good morning, good morning, good morning on this beautiful day to the Great Lakes Health Radio program on Power 96.5 FM and WUFO 1080 AM. Or you might be listening through one of the through a Google or one of the search engines. So I want to say welcome to everybody and thank you for listening to the Great Lakes Health Radio program with your host, me, Francesca Messiah, Manager Workforce Development for Kaleida Health. And I've been with Kaleida Health 20 years, and every day has been a really good one. I just had to add that. Well, the Great Lakes Health Radio program, this is the second half. So I'm not going to say too much about Kaleida, only that we are Western New York's largest healthcare system. And today on this topic, we are talking about an upcoming community conversation that's being hosted on October 18th from 3 p.m. until 5:30 p.m. at the Frank Merriweather Library, or affectionately known as the Merriweather Library, at the corner of Jefferson and East Utica. If you're not familiar, the full address is 1324 Jefferson Avenue, zip code 14208 for putting into your GPS system. Today's guest, well, let me tell you the topic. It's a community conversation called Beyond the Reproductive Years, age 35 and older. We're talking about women's health. We're also during this conversation talking about perimenopause and menopause, which we started this conversation a few programs ago, but we really don't talk enough about women's health. And our guest for today, we have a few guests for today. We have Dr. Sarah Burga. Good morning, Dr. Burga. How are you?
Excellent. I love your introduction, Fran. And it's so nice to be here.
Oh, thank you. And Dr. Burga is professor and chair of the Department of Obstetrics and Gynecology at the UB Medical School, the Jacobs Medical School, Jacobs School of Medicine. And also, we have a guest who is no stranger to our show, and that's Dr. Jalise Sosa. Good morning, Dr. Sosa. How are you today?
I am doing well, Francesca. Good morning.
Oh, good morning. And Dr. Sosa is a director, OB and GYN, that's OB/GYN, and Women's Health Program Development at Oishei Children's Hospital, which is, of course, part of Kaleida. And another guest who might be joining us later on is Kelly Marie Wofford, who is the director of the Erie County Department of Health, Office of Health Equity. So let's get started. Beyond the reproductive years, who is responsible for this brilliant topic about women's health?
This was really a collaborative effort, Francesca. We, as gynecologists, we often talk to each other, and we found that patients so often have questions about the changes that occur leading towards perimenopause and menopause, and they often find that they don't know what to expect. Then we also have patients who believe that they don't need to come see us anymore after they've had kids or after they've had a hysterectomy. And we just sort of got to talking and realized this is something that we really need to address within the community and take it outside of the clinic walls where, you may be limited by time and what you could discuss with a patient, and really get a sense with our community what their concerns are, what their questions are, to start that conversation going and to keep it going, hopefully in the next year. And October happens to be Menopause Awareness Month, with October the 18th, the day of the event, being World Menopause Awareness Day. And it just worked out perfectly that University of Buffalo, Kaleida, the Erie County Department of Health, the Erie County Office of Women's Affairs, the Office of Equity, Health Equity, and Catholic Health were able to come together and really work as a group to help our community get the answers that they want regarding women's health.
That's excellent. And I tell you, other groups that could have joined, the Girl Scouts could have joined, Black clubs could have joined, because we are all women and we don't know enough about. We probably know everything else except for about our health. So, Dr. Berga, where and when is it? And that's why we're having this conversation and this session is taking place. Where and when is the community conversation?
So it is, as we said, on Saturday, but the community conversation is all the time, right? Because people are constantly asking questions and trying to understand the change, as we sometimes refer to it. And there's a lot of mythologies out there. So I think part of our issue that we want to raise is that as new knowledge has evolved, and there's been a lot, it needs to translate into the clinical realm. And so I feel that that's really one of the gaps that we need to address, and we will be attempting to address. And we invite the kind of questions that people have always wanted to ask.
Yes. And again, it's Saturday, October 18th, 3 p.m. till 5:30 p.m. at the Merriweather Library, free and open to the public. So why was it important? Kelly's not here to speak up, but I know Dr. Sosa, Dr. Berga, you are, and I know you know this answer. Why is it important for medical and non-medical professionals to be part of the planning for Saturday, October 18th at the Merriweather Library?
I mean, I've been in the medical education world a long time, and our residents are trained in the core. And I often feel like core means, at the time that they're in training, how to deliver a baby, how to learn to do gynecologic surgery, and all of this is really important. And 4 years isn't just it just isn't enough to learn what they need to learn. And then I know just from watching this for many years that they go out to practice, and suddenly in the ambulatory environment, there's a lot of issues that they haven't really had any training in. And so there's been this gap that's continued for many years now. And there was a subspecialty that developed, reproductive endocrinology, to address part of this gap. But then it got more or less taken over by infertility. So I said, RE got added I, and when I came along, it really just diminished the training that we give to our residents in reproductive hormones. And so now there's really, I think, as big a gap as there has always been, and the knowledge is there, but we need to figure out how to get it to the people that need it.
I think it's really, we sort of live in a time where we realize that a lot of health occurs outside of the office, right? So you come for your once-a-year annual visit, you may come in for a problem, but so much of your life obviously happens outside of it. And we're not always there to answer those questions. We also know of the systemic issues that cause certain groups to be more negatively affected by health changes. So African-American women in some studies have been shown to feel like their symptoms related to perimenopause and menopause are not listened to in the office. They may experience more severe symptoms, may experience symptoms for longer at times, but these aren't issues that are specifically addressed at, say, an annual GYN visit. How to prepare for this, how to understand the changes, how to reduce certain symptoms. And then, as Dr. Berga mentioned before, because, again, of the history with how the healthcare system has treated certain groups, there may be mistrust. So we have safe options to help manage symptoms, such as menopause hormone therapy, traditionally known as hormone replacement therapy, where patients come in completely not understanding the safety of these medications, or previous thoughts that they may cause certain cancers and other conditions. And so being able to have members of the community who want healthcare professionals who could also share what the community pulse and voice is, who may help us address those specific issues related to inequity, where we're able to really bridge those gaps and not just sort of reproduce teaching or education geared only to those who are, of a particular group. We really want to be able to be accessible to our entire community. And we felt in order to do so, partnership with other community groups is important.
And I just want to say that what you just said, partnership with community groups is important. For this conference, something that, because I was part of the planning, we're going to ask the audience to ask your neighbor questions. We are encouraging you to ask questions. Like Dr. Sosa just said, you go to the doctor's OBGYN, you should go at least once a year. But you may have questions like 11 months out of the year. Bring some of those questions, please, 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 bring some of those questions with you that you have about your health on Saturday, October 18th from 3 to 5:30 p.m. at the Frank Merriweather Library. On that note, ladies, are there body changes we don't hear about that will be discussed? We hear about menopause, we hear about premenopause, but are there topics that you will be discussing that we don't hear much about?
I'm just going to say, in the world that I live in, which is the transition from having regular menstrual cycles, presumed fertility if desired, and then menopause, there's about a 15-year period of time, which we refer to by many names. One is perimenopause. A lot of people don't like that term, but it's short, and I think most people get what it means, meaning around the time of menopause. And the big finding that occurred a long time ago, 20 years ago, by a good colleague of mine, was that actually your estrogen levels, and we are not going to really talk too much about what estrogen is and isn't, but it's one of the hormones our ovary makes, actually go up instead of down. And so the cartoon that people are carrying around in their head is that there's this rheostat and the ovary just gradually dwindles and then you get to menopause. But Mother Nature designed a different program, and there's this burst of ovarian activity from like 35 to 50, and then there is a decline. And so I think it's very confusing for people because everybody doesn't get this addition to the cartoon that we've discovered. And so it's not been woven into clinical thinking very much. And then if patients don't know it, then they don't understand some of what's happening at that pretty long period of time. So I feel like in my world, infertility is suddenly jeopardized, and the same patients that are coming in who may be desiring later in life fertility are actually sometimes going through perimenopause. So that two areas actually are one area in my office, but I think for other times it's not fertility that's being sought, and they're just confused about how they feel. And so they may get dismissed, not heard. Really their physician or practitioner may not even fully understand how different the perimenopause is from the menopause.
Dr. Sosa, something that you don't think that we as women normally hear about, but that will be discussed.
I think one thing we're going to be discussing also is how these changes Dr. Berger mentioned affect so many organ systems in the body, right? It can affect your brain. It may affect someone's risk for dementia. It could affect muscle mass. It can affect your bone health. So connecting not just so the common symptoms we know, like hot flashes, but connecting it to the whole body and how the changes that occur in that 15-year span that Dr. Berger mentioned really affects every single organ system. And then not just telling us what it does, but now that we know how it could affect those organ systems, what can we do to optimize our health? so that we're here for a longer time, and that when we are here for a longer time, we're able to thrive in that time. We're mobile, we could move around, we could still function well, we still have good memory, things like that. So I think it's going to be a pretty rich conversation and really getting women to think ahead, 10 years from now, 15 years from now, 20 years from now. I know these changes are going to come, but what can I do now to make sure I optimize my health in preparation for this?
Mhm. Yeah, and listeners, yes, the topic is beyond reproductive years, age 35 and older. Men are invited because you might have someone who can't make it, a mom, a wife, a girlfriend, a daughter, a grandmother. You may have questions, something that they don't want to talk about. You are more than welcome to come and attend, and you're more than welcome to ask questions. And that's so true, because so many times you hear the things that women in your family or your friends have passed down, and hot flashes is one of them. Um, mood swings, that's another. Sometimes, and some of those can have truth, some can have myths, but something that we don't hear about as much, and I'm sure that you'll be addressing it, is exercise and bone mass. You know, what happens to the body? Why is it our bones are brittle? Why are, weight, why is weight training important? And weight training can be uh a water bottle, cans in your kitchen. It doesn't mean you have to take out a monthly gym membership, but just, topics like you talked about, weight gain, do you have to gain weight? So I mean, these are just some of the topics that will be discussed, as well as the medical ones, and such as women saying, well, I no longer not having children, so I don't need to go to the OBGYN. So those kinds of things, questions. What makes this community gathering unique?
As far as we know, and Fran, you might know because you know everyone and everything in this city. But our goal really is to have that conversation where the professionals, the women in the community, like you said, their family members, men, from all aspects of life are really there, not in this sort of top-down, we just tell you what we know and keep it moving. We really want to have that conversation where we go back and forth, addressing these community-led conversations. And I think that's what's unique about it. And I do want to let you know that this is just the first of many we plan to have. The goal is to really get our community focused and thinking about women's health all the time. It's not something that we only value when someone is trying to have a baby, and then after that, you're no longer important. Your health matters all the time. And we know that women are the ones that lead families, that lead communities, that really keep everyone else, in check. And so by prioritizing the issues related to women's health, we're really prioritizing our community. And I think it's, as far as we know, it may be the first in which we're really prioritizing women's health in Buffalo and having not just one singular event, but a series of events where we get the community and the professionals together in the same space and having that cross-pollination of ideas and answering questions.
Dr. Berga, in your opinion, what makes this conversation unique?
I was thinking one of my favorite topics, and this is to put a public spin on it on purpose, is called Saving Grandmother's Brain. And for many years, I used to talk about this at the American College of OBGYN, and it always got a large audience. And I don't think that it was because the medical professionals there just necessarily wanted to learn about their patients. I think they wanted to learn about themselves as well. And I think that's one of the amazing things is, like, as professionals who are women, we're actually part of the audience as well as part of the professionals, right? I mean, we are all going through this too. And so we understand as we age, our roles change. And so to highlight it, I call it Saving Grandmother's Brain because it's something that I think has a community spin as opposed to just a science spin.
Oh, yeah, no, that's great. Let me know if you want to do that's a great topic. That'll get everybody. Saving grandma's brain. Oh my God. Um, if you think now, will you or some of our other panelists, who are some of the other panelists before I even ask the next question? Who are some of the other panelists?
So we have Dr. Joshna Singh, and she is a psychiatrist with University of Buffalo who focuses primarily in maternity, mental health, maternal related mental health. But she is one of our premier psychiatrists in the area who really focuses on how women's health influences mental health and vice versa. So she'll be one of our speakers, which I think is really important. We talk a lot about the physical changes, but there are other mental health changes that occur too. So she will be there. And then Kelly Wolford, who is the director of the Office of Health Equity with the Erie County Department of Health, will be there. Kelly is also a treasure trove of knowledge and wisdom regarding the history of the city and the history of healthcare in the city. And she has been really key, especially in our planning, in really helping us to focus and hone in on the certain communities which, again, are more commonly neglected or overlooked when we address certain health issues. So she will also bring in that perspective as we answer certain questions, as we think about, how we may even change how we practice in the future.
Mm. No, that's great. And there's been a whole host of individuals who are part of the planning, including Commissioner Gail Burstein. So, now will you be talking about can someone ask questions about frozen eggs, freezing their eggs? Will that be something someone can ask?
You have the expert right here, Dr. Burga.
Okay. And endometriosis?
Oh, absolutely.
Okay. Keeping one ovary versus two ovaries during fibroids if you're having any kind of a hysterectomy.
Yeah, these are all things we could talk about.
Okay. And these are things that sometimes will come up in a conversation and people just kind of look at frozen eggs. Oh, okay. Because I just think that this is so great. If someone is under 35, are they encouraged to attend?
I'd say yes, because like Dr. Burger said, we're all going to get there one day. And
I'd be willing.
that is true.
Mhm.
Why not have the information now? Yeah,
Mhm.
absolutely. And if not for yourself, another family member who may not be able to make it, yeah.
Yeah. And I also say, because I know I work with a lot of younger people in high school and such in the area of workforce development. And you may want to come here and start a paper on women's health. I know all of your schools are asking for some type of a paper. This could be a good topic, and you can interview one of the panelists, all the panelists, just something for high schoolers or even college students to think about. This is a great topic. I always have that educational spin. Something we haven't discussed. We have a few more minutes left in the show. Starting with Dr. Sosa, what's something we haven't discussed and you want to make sure our listeners know about the upcoming conference Beyond the Reproductive Years, Saturday, October 18th, Meriwether Library, 3 p.m. to 5:30. What's something we haven't discussed?
I don't know if I think we've discussed all I wanted to, but I just encourage folks to come out. This is your time to be in a room with several different physicians, several other community leaders and ask those questions that you may, you're sitting with your girlfriends and talking, you're expressing your symptoms, and you're like, I wonder if XYZ. This is the time you will have we'll have 2.5 hours in which we could really get deep into it. So come on out.
Thank you, Dr. Berga.
I like to distill it into 3 sound bites. One is all women aren't the same. So I think I never get any pushback on that, by the way. All estrogens aren't the same. And there's a lot of detail that we've learned about in the last 20 years that really would be useful, I think, for anybody to learn, because the conversation with a provider is going to go better the more you know. And then not all progestins are the same. And if you just have those 3 topics in your brain as a structure for where you're going to park information, it's helpful, because we know that the timing isn't really rigid for how people transition through their reproductive years. And so different women need different things at different times. And so understanding that personalized approach to this stage of life, I think, is also really important.
And there are different things that can where you could be 40 years old and then all of a sudden you are in that stage of life. So there are things that can happen overnight. And I look at myself when people start talking about estrogen, when people start talking about different conversations, if I don't know anything, sometimes I just kind of walk away because I don't want to add any false terms to the conversation. But this is an opportunity, ladies, so we don't have to walk away. We can add. This is like a great educational community, fun conversation. There could be, I know there's going to be laughter. I know we're open to tears. This conversation is for us. And again, men, you are invited. So, Dr. Berga, Dr. Sosa, just say the title and where it is again in closing.
So this is Beyond the Reproductive Years, which is a community event on Saturday, October 18th from 3 to 5:30 at the Frank E. Merriweather Library at 1324 Jefferson Ave, 14208. Come out and get all the information you can about women's health, your reproductive health after 35.
And Dr. Berga, how old do you have to be?
You have to be any age.
Can you bring a friend or your entire posse with you?
You may. In fact, I've had that happen before, and it's always great. And, we don't want to leave out the members of our families who are older and have been through this before and still may have questions. So there used to be this kind of message out there is that you had to make a decision about hormones, and then if you didn't make it, you'd pass the magic window. And of course, we've discovered that that's not true, but that may not be out there. So any age, any stage.
Thank you. And ladies, doctors, I want to thank you so much. I want to thank Dr. Sosa with Oishei Children's Hospital. Also, I want to thank Dr. Berga, also with Oishei Children's Hospital, part of Kaleida Health, for being our guest this morning on the Great Lakes Health Radio program. My name is Francesca Messiah, Manager Workforce Development, and thank you for listening. And I hope to see you on Saturday, October 18th, 3 to 5:30 p.m. at the Frank Merriweather Library, Beyond the Reproductive Years. Bye-bye.